Thank you all for spending time with me today. Hopefully you will learn something new and obtain helpful information regarding regenerative medicine. This is Dr. Mary Ambach and I will be presenting. Dr. Christopher Rogers may be able to join us at the question and answer portion at the end of the presentation. So this afternoon, we're going to be talking about regenerative medicine for orthopedic conditions. This is our medical facility in Carlsbad, located in San Diego, North County. This is our brand new facility, which is a state-of-the-art facility. We have a large procedure room, and these are our cutting-edge equipments that we use for our innovative procedures. This is the lab area where our biologic therapies are processed. Dr. Chris Rogers is the founder of San Diego Orthobiologics Medical Group. He's a recognized expert and leader in the field of regenerative medicine. He serves on the board of directors for several regenerative medicine organizations. I joined Dr. Rogers' practice more than a year ago when I realized I wanted to come back to San Diego. I was with a renowned regenerative practice in Los Angeles called the Ortho Healing Center, where we treat Olympic athletes and other professional athletes. Dr. Rogers and I get invited to lectures in regenerative medical conferences and workshops, and we train other physicians in how to perform these procedures. We also author chapters in several regenerative medicine textbooks. So this afternoon, we're going to be talking about platelet-rich plasma and stem cell therapies. We will also be discussing commonly asked questions and scientific evidence on these therapies. In 2004, Nancy Reagan said, "Science has presented us with a hope called stem cell research, which may provide our scientists with many answers that have for so long been beyond our grasp. There's a lot of potential for this therapy, and it is incumbent upon us to maximize this potential and to use it safely and responsibly." So what is regenerative medicine? It's a new medical specialty that strives to restore health by harnessing the body's natural ability to heal itself. By using the unique healing qualities of our own cells, regenerative treatments can stimulate healing, reduce inflammation, and decrease pain. We are like farmers. Farmers use soil, seeds, fertilizers for plants to grow and to keep them healthy. In order for us to repair tissues, we need the cells, which are the seeds, the growth factors, which are the fertilizer, and the scaffolds or the tissue framework, which are soil. We use orthobiologics for our regenerative therapies. What are orthobiologics? These are cells and substances that are produced by cells that are used for the treatment of orthopedic conditions. They promote the body's intrinsic capability to heal and offer a viable option for patients who have failed conservative care or are not appropriate surgical candidates. Just like there are many different ways of cooking a dish, there are many different ways of preparing these treatments. The choice of orthobiologics and its preparation is tailored upon the patient and the condition we are treating. Let's talk about the first biologic, called platelet-rich plasma, or PRP. PRP is a preparation of highly concentrated platelets above what is normally contained in our blood. Platelets are smaller than your other blood cells. They're the first responders to injury. You're familiar with other blood cells, the red blood cell which carry oxygen, and the white blood cell which fight infection. So why are we interested in platelets? That's because platelets make the cell fertilizer. They contain thousands of growth factors that stimulate repair, tissue building, and formation of blood vessels. So let's discuss the different orthopedic conditions that PRP can be used for. Tennis elbow, or what's called lateral epicondylitis, is the most common overuse syndrome in the elbow. It involves irritation of the tendon that connects the forearm muscles to the outside of the elbow. We see this commonly in patients who play tennis, golf, or other sports that involve repetitive motions of the wrist and the arm. There are many high-quality research that supports the use of PRP for lateral epicondylitis. As you will learn later in the lecture, there are many different kinds of PRP, and it's the leukocyte-rich PRP that is found to be more effective for tendon injuries. Dr. Mishra is an orthopedic surgeon from Stanford, and he performed the first studies on PRP and tennis elbow. He did a study of 230 patients, which showed that PRP provides a similar rate of success with lower costs and less risks than surgery. This is a study that compared using PRP or surgery in about 80 patients for lateral condylitis. And as you can see in the table, the PRP group had better pain improvement and percent pain reduction than the surgery group. This is what a tennis elbow injury or tendon tear looks like on ultrasound. So you can see the black region is where the tear is. And after PRP injection, this ultrasound was done 3 to 4 months after the treatment. You can see there's growth of fibers or this white line into the injury site, suggestive of healing. So what other orthopedic conditions can we treat with PRP? The most common orthopedic condition that has been studied for the use of PRP is knee osteoarthritis. This is a study that collected 14 different high-quality studies with a total of 1,400 participants, and they compared PRP injection with saline and other commonly used treatments like hyaluronic acid or gel injections and steroid injections. And they found that injecting PRP into the joints was more effective in the treatment of knee osteoarthritis in terms of pain relief and functional improvement compared to the control. There are hundreds of research on safety and level 1 evidence, which is the highest level of clinical evidence assigned to studies on using PRP to decrease pain and increase function for knee osteoarthritis. Lumbar disc degeneration is another condition that causes low back pain where PRP can be used for treatment. There are several studies that have shown the use of PRP to treat the symptoms of degenerative disc disease. This is one such study where a single injection of PRP in 47 patients showed significant improvement in pain and function, which were maintained up to 1 year. There was no side effects of disc infection, neurologic injury, or progressive disc herniation. They did a follow-up study that showed that there was continued improvements up to 2 years. So these are the other orthopedic conditions where PRP is used. We talked about knee osteoarthritis, tennis elbow. There's other conditions that can cause spine pain, like joint osteoarthritis or irritated nerves or sciatica, that we can also use PRP for. Tendinopathy, like gluteal tendinopathy in the buttocks, patellar tendinopathy in the knees, rotator cuff tendinopathy in your shoulder, and other conditions are also treated with PRP. So how do we make this PRP? If you are interested, we have a YouTube channel that shows more detailed information on how all these different biologics are made. Through a routine blood draw, about 2 to 4 tablespoons or 30 to 60 milliliters of blood are obtained in an outpatient setting using aseptic technique. The PRP then undergoes a centrifugation or spinning process where the platelets are concentrated and the whole blood is separated into 3 layers. A top plasma layer, a middle PRP layer, which also contains some white blood cells or leukocytes, and the bottom red blood cell layer or RBC layer. This RBC layer is removed as this can be harmful to the tissues. The PRP or the middle layer is then separated for injection. The platelet concentration and composition will vary depending upon the process selected by your physician. That is why it's very important to select a physician that is experienced and skilled in regenerative therapies. So what other cells do we use in clinic? Stem cells have been a hot topic that has generated a lot of interest. Let's talk about these cells briefly. As you have learned in biology, a typical cell undergoes cell division and makes copies of themselves, to support development and growth. Stem cell is unique in that it not only makes a copy of itself, it also differentiates into other cells. There are two main types of stem cells. The embryonic stem cell, which are derived from embryo that develop from eggs that are fertilized in the laboratory. These are used for research purposes only. We do not use embryonic stem cells for our treatments. The other type of stem cell is the adult stem cell. Adult stem cells are specialized cells that are found in our tissues and can generate different cell types for the specific tissue in which they live. In orthopedics, we are interested in specific adult stem cells called mesenchymal stem cells, or MSCs. Arnold Kaplan is a professor of biology at Case Western Reserve University in Cleveland, Ohio, and he's considered the father of MSCs. He named MSCs more than 25 years ago. Where do these stem cells live in our body? They have discovered that these mesenchymal stem cells are found in our microvessels, for which they're called parasites. When there's tissue injury, and through appropriate microenvironment stimulation, these cells become MSC and initiate the healing process. How do stem cells promote healing? These MSCs act as mobile drugstores. They have hundreds of molecules that they release once they are activated that are involved in tissue healing, inflammation control, and fighting infection. What kinds of stem cells do we use in clinical practice? We use cells that are derived from a patient's own bone marrow and fat or adipose tissue that are not processed by enzymes. These treatments are compliant with current FDA regulatory guidelines. Birth tissue-derived stem cells from amniotic tissue or umbilical cord blood are not permitted by FDA. The safety and efficacy of these products have not been proven. In fact, there were cases of bacterial infections reported in patients who had received umbilical cord blood injections. Our colleagues tested these products. They confirmed that they do not contain live stem cells. So beware of clinics that advertise birth tissue products containing stem cells. They require FDA approval of a biologics license before they are allowed to be marketed to patients. So which cell-based therapies are compliant with FDA guidelines? The only cell-based therapies that are allowed by the FDA at this time are PRP, or platelet-rich plasma, bone marrow-derived cells, and adipose tissue-derived cells that are not processed with enzymes. Stem cell therapy is safe. There are several peer-reviewed papers that have shown the safety of bone marrow and adipose-derived cells. This is one such paper wherein they followed 2,300 patients, and they followed them up for about 8 years. They showed no serious adverse events in these patients that have undergone stem cell therapy derived from bone marrow. This is another paper by Dr. Hernigow, who published many important bone marrow stem cell studies. He studied 1,800 patients and followed them up for 12.5 years. And he showed that there was no increased risk of cancer with bone marrow-derived stem cell treatments. Another study using processed adipose tissue with a large number of patients followed for several years. And again, no serious adverse events are noted. Our clinical experience reflects these findings, with no serious adverse events from the procedures. The most common adverse effect our patients report are slightly increased pain for a few days, which is to be expected as this is a part of the healing process. So how many stem cells are in these tissues? I was debating whether to include this slide or not, because there's just such wide variability in these numbers and count of cells found in literature, and even in the same patient. The important concept in this slide is that adipose tissue contains significantly more stem cells than bone marrow tissue. And as we have said, there were no live stem cells that were found in birth tissue products. Although bone marrow has decreased number of stem cells compared to adipose tissue, it does have a high concentration of platelets, adding to its therapeutic effects. It is important to note that bone marrow and adipose tissue contains cells and proteins in addition to the stem cells that contributes to its therapeutic effect. The source of the cell tissue that we use depends on multiple factors, including age, medical comorbidities, severity of the condition, and other factors. Naturally, we can't aspirate fat from a skinny patient. The patient's preference also plays a role. So you can imagine patients are more willing to have their fat taken out than their bone marrow. So these are other orthopedic conditions where stem cell therapy is used for, as listed here. They're used for joint arthritis, osteoarthritis, tendon injuries or tendon tears, ligament injuries like ACL tears, bony injuries, and degenerative discs in the lumbar spine. The second part of our webinar is to discuss the myths and the facts about these therapies. There are hundreds and thousands of articles in peer-reviewed journals that have been published regarding these therapies. I did a recent search in PubMed, which is a database of research and journals and other references on science and biomedical topics. As you can see, there's significantly increased published articles, especially in the past 10 years, for both PRP and stem cell research. More and more high-quality research is being conducted for these treatments. There's about 60 randomized controlled trials, which are high-quality studies, proving that PRP works as good or better than standard orthopedic care for about 12 orthopedic conditions. So as you can see, there's lots of evidence for these therapies. Chronic tendon tears happen because of repetitive injury and impaired or incomplete healing response of the body to these injuries. Cell therapy improves the healing by stimulating production of mature tissue to repair these tears. This is a patient with a 1-year history of Achilles tendon tear that was treated with an injection of fat-derived stem cell therapy. Patient started having improvement of pain at 1 month, and at 3 to 4 months, he had zero pain and no activity limitations. A repeat ultrasound was done 1 year after treatment, and as you can see, the black region where the tear is located is resolved, suggesting healing. This is an actual patient of ours. He is a professional soccer player who had a significant tear in his patellar tendon. And after 1 injection of fat-derived stem cell therapy, as you can see, there's resolution of the tear as early as 12 weeks or 3 months after treatment. He was able to play soccer with no problems. Research have been published showing that cell therapy can reverse or improve degenerative changes in the discs. The disc is the cushion between the vertebral bodies in your spine, and over time they get worn out and create tearing and degeneration. We published a case series of 20 patients where we injected bone marrow cells and PRP to their degenerated discs. We found that 93% of these patients showed greater than 50% pain relief and improved function. There was no ER visits, no hospitalization or surgery for these patients that received the injection. The second objective of our study was to evaluate utilization of healthcare services, and we found that 80% of these patients decreased their medication use. There was definitely decreased utilization of medical services, translating to decreased healthcare costs overall. This is one of the patients that was enrolled in the study. There's a small tear in the posterior discs as pointed by the white arrow, and this is resolved when we did a repeat MRI in 6 months. This is a study by Dr. Petin where he injected bone marrow concentrate for degenerative discs. He enrolled 26 patients, all of whom are surgical candidates for fusion or disc replacement. And his study showed that the average pain reduction in these patients is 73%, and the average functional improvement is 68%. 40% of these patients improve in their 1-year MRI, and none of the patients had worsened degeneration in their discs over the course of the study, which is 3 years. A lot of patients come to our clinic asking us if we can improve the cartilage in their worn out or degenerated knee. And the exciting thing about these therapies is that this is now a possibility. This is an arthroscopic picture. An arthroscopy is a procedure when you insert a camera into the knee joint. And this is showing us a knee joint showing improvement or growth of the cartilage, which is the white tissue, after fat-derived stem cell therapy for knee osteoarthritis. This is a study showing an MRI with a special dye that detects poor quality of cartilage. And after treatment with bone marrow-derived cells, there's improvement in these areas. Another study showing a special MRI with a dye that detects the cartilage protein. And after one injection of processed adipose tissue, there was more cartilage tissue or improvement of the quality in about half of patients. And there's decreased pain in majority of the patients. If you have bone-on-bone arthritis, this therapy is probably not going to regrow your cartilage. But lots of studies are showing good results with these patients, even though there's no cartilage improvement. And that's because the cell therapy works in other ways. It kills cartilage-destroying cells. It regulates inflammation. It increases blood flow to the region, and it boosts the cell battery, thus improving clinical outcomes. So do most meniscal tears require surgery? This is not true. Meniscus is the cushion between your thigh bone and your leg bone. This can get worn out and create tears. Meniscectomy is a surgical procedure where a portion of the meniscus, which is the torn meniscus, is shaved off from your knee joint. Conservative treatment and meniscectomy have been shown in studies to have equal outcomes. There is no difference that was shown in outcomes between meniscectomy and physical therapy, and also no difference between meniscectomy and sham surgery, where they put a camera into the knee joint and do not perform any surgical procedure. They have also found that the arthritis in these patients undergoing meniscectomy was increased in 60% of these patients, which just makes sense because you're removing a portion of the cushion that supports your knee joint. Some types of tear, like a bucket handle tear, for example, do require surgery. Or if a joint is unstable and have severe mechanical symptoms, this may require surgery. However, most of the cases of meniscus tear, especially the degenerative tears, can be treated conservatively. So we get asked by our patients a lot if they are too old for stem cell therapy. We know that stem cells decrease with age. We don't know at this time if there's an ideal number or count of stem cells to treat a specific injury for it to be effective. But what we do know is that we have treated a number of these patients in their late 80s and some in their early 90s that did get benefit from these therapies. This is because of the reasons that I just explained earlier on how this therapy works. This is a study that have been published that showed that 80 to 92-year-old patients obtained benefit from an injection of a fat-derived cell therapy. So is knee replacement surgery better than stem cell therapy? Though surgery is sometimes the obvious solution for certain severe cases, we have seen great results with stem cell therapy for osteoarthritis, where patients are able to delay or avoid surgery. There's abundant evidence for the use of PRP and bone marrow and fat-derived cell therapy for knee osteoarthritis that it makes it a great alternative to knee replacement. And as we know, surgery can have complications like blood clots, infections, and complications from general anesthesia. It also involves prolonged rehabilitation after the surgical procedure. So the decision is made by the patient and the physician based on the patient's condition, medical comorbidities, level of function, and other factors. This is a study that compared bone marrow aspirate injection and total knee arthroplasty. They enrolled 30 patients who had both knees with severe knee arthritis. One knee was injected with bone marrow stem cell injection, and the other knee underwent knee replacement surgery. And after 12 years, both knees did improve, but 66% of the patients preferred the stem cell injected knee. There were more complications with the knee replacement surgery that they found. So can any healthcare provider provide stem cell therapy? This is not true. You want to seek board-certified physicians who are specialized in diagnosing and treating orthopedic conditions. You want to seek physicians who have advanced training in performing these procedures under imaging guidance and have the skills and experience in knowing what's the best regenerative treatment for your specific condition. You want to seek out clinics who are compliant with FDA regulations and, most importantly, care about achieving the best results for their patients. This is a regenerative medicine registry called Data Biologics that's co-founded by Dr. Rogers. It's a cloud-based registry that's very easy to use, very patient-friendly. And through this, we can track our outcomes or even complications if we have any. And we can give our patients real data on our outcomes with these therapies. It's important to collect data, not only to track outcomes, but it's also useful to guide future decisions made by insurance companies and regulators. So that ends our lecture. Thank you for listening. We hope this provided helpful information regarding cell-based regenerative therapies. Before we proceed to the question and answer portion, I'd like to thank Doctor.com for their help with this webinar. We're also going to invite Dr. Rogers to join us for the question and answer portion. And hopefully, you were able to type in your questions and we can answer them to the best that we can. Okay, let's see if Dr. Rogers has joined us. First question, with regards to adipose versus bone marrow, if someone is thin or has low fat, at what point does it become problematic to use adipose? So, as we have said, there's a certain amount of fat that we need to collect to be able to obtain an appropriate sample for your treatments. So right now, there's no specific measurements or percent of body fat that we use, but it's mainly a clinical decision that we make based on prior experience and how much fat we need for their specific condition. Okay, next question. How do you decide between PRP and stem cell therapy? So this depends on your orthopedic condition. Most mild injuries or mild conditions like mild osteoarthritis, mild tears do respond really well to platelet-rich plasma therapy. When your arthritis becomes moderate to severe or your tears become severe, then we tend to favor the stem cell therapy because it's more potent. Has a stem cell therapy yet become an insurance covered for this procedure? Unfortunately, right now, this is not covered by insurance yet. Okay, next question. For cervical nerve inflammation, would PRP be a treatment to consider? So we use PRP for sciatica or nerve irritation in the low back, and we have used them as well for radiculopathy or nerve irritation in the neck. There's not as abundant of studies with the use of PRP for epidural injections, but there are several, and these are based on the PRP's ability to heal nerve injury and provide anti-inflammatory effects. Next question. Are you performing these regenerative therapies with ligament or joint injuries? Yes, we are. Next question, can procedure be used for arachnoiditis? There's no studies that I know of or published literature regarding the use of these therapies for arachnoiditis. I may be wrong, but we haven't used it. I personally, Dr. Rogers, I don't think has personally used this for arachnoiditis. Next question. Can this help for arthritis in the thumbs? Yes. Unfortunately, in the upper extremities, aside from arthritis in the shoulder joint, arthritis in the thumb is the second most arthritis that we use these therapies for. And they do help significantly in decreasing pain and improving function in the thumb. The thumb is a little more complicated to treat just because we use it every day and it's a very painful structure. But we did get some benefit from these treatments from both PRP and stem cell derived therapies. Next question, can these treatments be used when cancer has metastasized to the bone? Currently, we don't use these treatments if patients have active cancer. If patients do have a history of cancer, we get a clearance from their oncologist, and most of the time this is not a problem as long as the cancer is treated or not active. Next question, do you have an approximate timeline on when you may be starting to reopen the clinic and perform PRP procedures? Yes, in fact, we are planning to open the clinic on Monday to start doing some procedures and seeing patients. Next question, do you use these therapies on the wrist? The answer is yes. We have used these therapies, both PRP and stem cell therapy, for joint arthritis in the wrists, ligament injuries, and tendon injuries. Next question, can a procedure be used for shoulder bone spurs? So currently, the treatments does not have effect on dissolving bone spurs. Bone spurs is a part of osteoarthritis. And the therapies help for improving the joint inflammation and sometimes the quality of the joint tissue, but it doesn't do anything to dissolve or remove the bone spurs. Next question.
Dr. Ambach, can you hear me?
Yes.
Yes, thanks to technology, I'm here.
Hi, Dr. Rogers. Welcome to the stage.
Hello. Yeah, glad to join you. A fantastic job so far.
So I have, Dr. Rogers, if you can hear me, I can read out the questions to you and you can feel free to join us and answer. Okay, next question. For rotator cuff tears, how do you decide between a PRP and stem cell therapy? For milder injuries, we have great success. Like, for example, if it's a small rotator cuff tear or tendinopathy, with using PRP therapies. But when the tear becomes large or more advanced, we favor the stem cell therapy because it's a more potent treatment. Next question, what is the recovery time for each treatment? So after the injection, there will be a few days, usually about 3 to 5 days, wherein you can feel increased maybe discomfort in the area, and this is what we call the inflammatory phase. So during this first week, you're not allowed to do anything strenuous. You're up and about, you're doing regular activities, but usually just light activities. And the second week after the therapy, that's when you start physical therapy or rehab. We do have specific protocols depending on the treatments that we used. And usually by the end of second week, start of or third week, depending on your condition, you can start slowly getting back into some sports-related activities. So with regards to recovery, it's really a few days of downtime, light activities. Then after that, you can start progressive exercises as tolerated.
That's particularly important for our athletes. If you go to our website, you can see a story about one of our professional golfers that we treated recently. He was right in the middle of this professional season, large rotator cuff tear, did not want to take time off and miss the ability to compete professionally. He was actually able to go back and compete within 6 weeks, and surprisingly, 2 months after treatment, actually won a golf tournament. So a very good outcome for a very bad rotator cuff tear for this professional golfer.
Next question. How long does stem cell therapy last? I heard 2 years. You want to answer that, Dr. Rogers?
So we've been treating patients now using stem cells from bone marrow and fat for more than 5 years. We're actually publishing the results of some of those patients in a medical journal soon. What we're showing is that at least 90% of patients are showing some response. And of those patients that do show response, the vast majority, more than 90% of them, are able to preserve their benefit for around 3.5 to 4 years. Unfortunately, we continue to age and we continue to re-injure ourselves. So our patients will come back after 3 or 4 years and perhaps need a repeat treatment or new treatment. And we're developing technology that will allow us to store your stem cells in the future. So when we take those cells out, we can store them in a FDA inspected facility. These cells are frozen and they survive for 20 years or more in the freezer, and then we can re-inject them without having to go through the harvesting procedure that we typically do. So this will be a significant advance to the field. This is a technology that most clinics cannot offer. This is something that we're able to offer through our unique relationship with our research company.
So in a related question, Dr. Rogers, we have a question asking, are you going to have a both knee study start anytime soon?
Yes, we promised that to many of our patients, and that may be what that question is coming from. We have several different studies that will be launched before the end of this year. Very likely one of them will include patients who have knee arthritis in both knees. There are some new developments that will be also available for those patients. So if you want to talk to me or Dr. Ambach in the clinic, we can give you the details about that.
Thank you. There's another question regarding insertional Achilles calcific tendinopathy. I was told these options would not work for me. Has anything changed since then with these therapies?
Yeah, Dr. Ambach and I have treated these. These are particularly difficult conditions to treat. The tendon, where it attaches down to the heel bone, becomes so degenerated that the cells become confused, and instead of them turning into tendon cells, they turn into bone cells, and they manufacture minerals that create this deposit within the tendon. So we find that the therapies that we offer with PRP or bone marrow or fat-derived stem cells can be helpful in healing the area around the mineralized deposit and may help decrease the pain and swelling. They typically do not remove the mineral component, and there are some non-surgical procedures that can be performed to do that. In the very severe cases, those typically do require a surgical procedure.
There's a question with regards to how are stem cells collected. We, as I mentioned earlier, we do have a YouTube channel, and it has detailed information on how we process or collect our bone marrow or adipose tissue therapy. But basically, it's a same-day procedure. We aspirate your bone marrow or collect your fats first, and then that gets processed in our lab for about 20-30 minutes. And then after 20-30 minutes, we go back to the room and perform your procedure. So it's a same day procedure. There's little use of or the need for analgesics for the procedure. Usually patients tolerate it really well with no anesthesia or a strong analgesics. Can this webinar be saved? Yes, we are. We have a recording of this webinar, and we will make it available for those people that have not had the chance to join us. Another question, Dr. Rogers, can PRP or stem cell therapy help a person heal from neuropathy?
Yes, so neuropathy, there are many different causes of neuropathy. Probably the most common that you hear about would be a patient who has diabetes, and now that the high sugar levels have caused damage to the nerves. There is research that has been performed in this area, but I would say compared to the other topics that we talked about today, the research is very early. And so there have been anecdotal cases where injecting PRP or stem cells around the nerves has been shown to decrease nerve pain, improve nerve function, regenerate nerves. I would still characterize this as very early, but be rest assured that many doctors are working on this challenge because, as you know, many patients suffer with neuropathy. There are other causes of neuropathy, such as patients who have thyroid diseases or on certain medications, and sometimes addressing the primary cause can also be helpful for alleviating the symptoms of neuropathy. But this is something we're very interested in. We also see patients who maybe had spine surgery or had a spine injury and have persistent nerve damage, the nerve in their spine, and we're also looking at the possibility of treating these types of nerve injuries. So we're very optimistic. The basic science has been very promising, but there's still a lot of work to be done.
Thank you. Do you have an opinion about second treatment being an increased benefit to knees?
There's actually data on this. There's been a couple of published papers that show that repeat treatment is synergistic and beneficial. There was one study in particular where stem cells from fat were used to treat knee arthritis, and they actually measured the thickness of the cartilage, the rate of change. And so MRIs were repeated every several months, and after about a year, you could see that the rate of cartilage growth was decreasing. So the cartilage was growing at a slower rate. A repeat dose of stem cells was given, a second injection, and then the rate of cartilage growth increased for another 6 months to a year after that second dose. So I do think that for very severe knee cartilage damage or for other joints, repeat dosing will be advisable for some patients.
Dr. Rogers, have you ever healed nerve root inflammation or Tarlof cyst with your treatments, also called perineural cyst?
Yeah, for those who don't know what a Tarlof cyst is, a cyst is just a fluid-containing structure. They're generally benign. They're not tumors. And so cysts can form anywhere in the body. When they form on the nerves in your spine, this is named after Dr. Tarlof, as many things in medicine are named after doctors. So they're generally thought to be benign, and typically a cyst on the nerve in the spine does not cause pain. But to your broader question, have we ever treated patients who have nerve pain in their back? And the answer is absolutely yes. We've treated patients who have herniated discs, patients who have spinal stenosis, other conditions that may irritate the nerve in the spine. We've used PRP predominantly. There are some other molecules that can be derived from the blood that have been also shown to be helpful for nerve pain or nerve inflammation. So we do have experience, and this is where that data biologics is very helpful. That software where we collect data for all of our patients who receive treatment now, it's allowing us to collect data that's not available anywhere else, and we can share the results of each of these types of conditions that we treat.
There's a lot of questions here regarding our YouTube channel. So if you go to YouTube, you can search, type our name, the name of our clinic, San Diego Orthobiologics Medical Group, and it will take you to our YouTube channel. Rather than a lumbar fusion, should I consider stem cell treatment?
So Dr. Ambach and I are both experts in the field of spine care. I've been treating spines for more than 20 years, and the general consensus among the experts is that most people do not need a spine fusion, but there are patients who do need a spine fusion, and it really has to be evaluated on a case-by-case measure. But spine fusion is generally reserved for a patient who has failed all reasonable conservative efforts or has a severe degeneration of the spine that's resulting in gross instability of the spine. Common conditions would be something like spondylolisthesis, which is a big word that simply means that the discs or the joints have degenerated to the point where the bones are now slipping apart. This now jeopardizes the spinal nerves, to which there could be nerve damage. Those patients generally do well with fusion. There are some other scenarios, but the most common scenario in a spine fusion, where patients considering spine fusion, would be the patient who has disc degeneration. And disc degeneration comes in actually 7 different shades of gray. So if it's the most severe form of disc degeneration, a fusion may make sense. But if it's in the more mild to moderate forms of degeneration, we've had actually very good results using just simple cell therapy.
All right, last question. Is repeat treatment for knees time sensitive?
Well, in medicine, you know, the old adage, a stitch in time may save 9, is absolutely true. So actually, we prefer that you folks take care of yourselves before things happen. So stay strong, stay healthy, eat good food, get to bed on time. And that's the best preventive medicine known to man. That is, we cannot overemphasize the power of exercise and good sleep and good nutrition. Those are very powerful preventative treatments. However, once something does occur, which usually by age 50, something will occur, one joint will develop arthritis or one tendon will start to tear just from use over 50 years or more, then those are the ones that we want to catch early and treat them. The tears that are in the tendons that are small can be easily treated with a simple PRP procedure. The ones that are larger need more help from either bone marrow or adipose stem cell therapy. But we've had patients who've had symptoms for, you know, many decades where we've seen benefit. So the nice thing about the human body is it can always heal.
Thank you, Dr. Rogers. Is there any last words that you want to say to our participants?
Well, I want to encourage each of you to continue to make healthy decisions, and the efforts that you make taking care of yourself go a long way in conjunction with the treatments that we offer. I think after listening to this talk, you realize that our clinic is very heavily focused on not only following the good scientific evidence that's available in this published scientific literature, but we also contribute to that science. And we think that's something that differentiates us from many other clinics that you might look at. We appreciate the opportunity. I know a lot of you are our patients and are attending today, and we appreciate the opportunity to care for you. We value your trust, and we enjoy working with each of you.
Thank you, everybody, for listening, and we hope this was helpful and provided you information regarding this topic. Thank you.
Thank you.